changing myself physically was a big change. It's something very powerful. Like, I'm so happy this is happening. I'm changing. I'm being myself.
Hello, this is Dr. Stephen Evans from Outlook Magazine. Today, we are excited to be talking to Dr. Christopher Salgado from Constructive Surgery Associates here in Miami, Florida. Dr. Salgado is a board-certified plastic and reconstructive surgery physician who specializes in gender surgery and genitalia surgery. He is one of our leading transgender health and gender affirmation surgeons in the world, who specializes in male to female and female to male reassignment surgeries. He has authored over 120 peer-reviewed scientific articles, and he has edited 3 books, one entitled Gender Affirmation, Medical and Surgical Perspectives. His work has regularly been featured around the world by 10 top news outlets, including CNN, Channel News 7, the Miami Herald, NBC6, and Univision. He's been practicing over 20 years and has privileges at Palmetto General Hospital and Coral Gables Hospital. Dr. Salgado, we welcome you today to chat with us about your work.
Thank you, Steve.
Hello, welcome. This is an amazing topic. My background is actually in medical education. I was a curriculum consultant at the University of Kentucky College of Medicine and the clinical director of clinical education for the FIU College of Medicine when they started. So this is a fascinating topic, I think, for a lot of us. Tell us how you got started in surgery and how specifically you got started in this type of surgery.
Thanks, Dr. Steve. So really since high school, I wanted to do OBGYN. And then my uncle's an OBGYN in Puerto Rico. And so from there, I got interested in medicine in general. I was thankfully, I was at Boston University for undergrad and then went to Georgetown for medical school. And then at that point, they didn't really have a clear track into plastic surgery. So I went into general surgery at Georgetown. And then by the time I became a third year there, then they had a program for plastics. I ended up going to Rochester, New York for plastic surgery. And then I had a 4-year stint in the military because they paid for my undergraduate studies. So I was a major in the U.S. Army for 4 years. And then after that, I was able to, and I practiced plastic surgery in Texas. After that, then I was able to go to Taiwan. And it really was in Taiwan that I got a lot into the genital surgery field. It's a field which has been understudied for quite some time, and particularly back in 2004, which is where I went to Taiwan. I spent 10 months there. And that's where I became really exposed to transgenderism and transgender people. It was in Asia. As you know, Thailand also is a very famous center for transgender surgery. So I spent some time there as well. So it really became twofold. One was an interest in the people and how it really feels like it's, you know, they're so grateful when you operate on them, and that they feel like you're relieving them of a cancer. They feel that they were born with this major birth defect that they can't, when cancer, and with people with cancer, they're able to tell the world, hey, I have cancer. But with transgenderism, it's sort of hidden. And so, and unfortunately hidden. And so when you're able to relieve them of this birth defect that they feel that they have, then they're so grateful. So it was a combination of that, in addition to the fact that the scientific aspects and the fact that it's so understudied and it's so easy to publish in the field were two things that really got me into the genital aspects. And then from there, I was able to, I went to 2 academic universities at Robert Wood Johnson and then Case Western. And then it was in Miami. I've been practicing 20 years. It was in Miami where I really became more involved with transgenderism and operations on people that needed these, these pretty invasive operations.
My dissertation topic is on actually patient-centered medicine and how physicians bridge the gap from purely treating the disease or the illness to actually working with the patient and what works best for them, and getting to know the patient, coming up with a treatment plan for them. This is such a huge part of what you do, is not only just performing the surgery, but getting to know the patient and understanding the psychological parts, the relational parts, the family parts of them, and helping them with that process. I'm sure there's a million questions people have in how your office works with people in the pre-process, and how when people come to you, their first questions. What are some of the first questions that people have when they sit down and talk to you?
So, Dr. Steve, it can be really a whole range. We see patients referred from the pediatrics endocrinologist at Miami Children's, who's excellent. And so they can be as early as 12 or 13. Or we can see them, a veteran from the Miami VA that was referred, or different VAs around the US. So they can be questions from as early as, oh, do you have a mental health therapist that you can refer us to? Because it's a very early diagnosis of a transgenderism, or it could be someone who's already been undergone mental health therapy, endocrine, the hormonal therapy, and already had some of the operations. So it's really a wide range of questions.
Mm-hmm. And what is some advice that you give people when they first start the process? I know they have cases vary from person to person, but what are some of the pieces of advice you start to give people as they start to look at, is this type of surgery right for them? And is it something they want to do?
Right. So a lot of, I think we've done many surveys on our patients, and we have an intake form, and most persons that are gender nonconforming, of course, or transgender, feel that they were wrongly gendered from the age of like 3 or 4 or 5. So it's a very early age. This is one thing I try to stress when I give talks is when you have a little bit more of the conservative people that might not believe in the surgery or might not support it, I tell them that transgender people and gender nonconforming, they didn't just wake up one day and feel like they want transgender. And, this is something that they have been suffering with for many years in most cases. And they don't want to undergo these invasive operations, but this is something that they need to do so that they can have their phenotype conform with their gender identity. So what I tell people that I encounter in the office or anywhere that are transgender, gender nonconforming, I tell them and a lot of them know this, I think, but their identity that they whatever they identify with, as long as they feel comfortable in their body, they don't have to undergo any surgery. If you have a transgender woman who starts, let's say, wearing a little bit of makeup or dressing as a woman and hasn't even undergone hormonal therapy, as long as they feel comfortable in their identity, and there's different scales, gender dysphoria scales that we use. We also evaluate patients with. If they feel comfortable in their identity, they don't have to do any surgery. Hormonal therapy will help them, and a lot of times patients do undergo hormonal therapy after initially seeing a mental health therapist. It's important to get the mental health therapy diagnosis because thankfully now in the United States, insurance covers these procedures. And I think that's one reason we were sort of behind the 8 ball compared to Europe and Asia, is that in the United States, this wasn't really covered by insurances. And I've been practicing 20 years. I've been doing specifically transgender surgery for 10 years. And so I got to see the evolution of insurance companies, and I've sat on some insurance boards as well, sort of fighting for this. And I got to see the evolution of insurance companies covering these procedures. And so I will often say that, if you then get the diagnosis of gender dysphoria, then you're going to get the hormonal therapy covered. And so, and then in addition to many surgical procedures. So once a patient undergoes mental health therapy, then goes on hormonal therapy, if they feel comfortable at that point, you don't need to have any surgery. But then if they have dysphoria, and I say, what's this dysphoria related to? If it's the face, because it's a transgender woman, transgender men undergo facial masculinization, but it's a lot more rare. A lot of times, and we could talk about, transgender men and then women and the differences there from a surgical standpoint. But if they want to undergo, if they're suffering from dysphoria related to their face, then these are procedures that we can entertain. Or if it's their chest, some of them, it's nothing except for their genitalia. When they look at themselves in their birthday suit, if you will, then if their dysphoria is related specifically to their genitalia, then that's what we'll address. So I definitely never push any patient into what procedure they should have. However, I will have some that come in with the open-ended question. saying, I'm a transgender woman, I'm not passing. What would you, what do you think would help me pass? And now we've actually done studies in that, particularly when I was at the university, to see what helps patients pass, for example. And I'll give you some examples. For transgender men, some of the top procedures that we did surgically, and even from a hormonal standpoint, was hormonal therapy. So it was getting on T and growing hair like your beard. Also, the trans man, if they got a receding hairline, they were sort of happy about that, and that helped them pass more. That's from a hormonal standpoint. And also from a surgical standpoint, it was the top surgery. It was getting a mastectomy. Those were the top reasons why people were able to pass more readily for trans men. For trans women, it was from a facial surgery standpoint, it was the frontal bone region and reducing that. And that was really the top reason why that allowed the top surgical procedure to help trans women pass. And it was an augmentation as well. So they'll come in with different questions, and and I definitely spent a solid hour with them, talking to them about all the different aspects of their transition, and I try to pinpoint where the dysphoria is coming from, to try to help them with the dysphoria.
And I think that's a really great point. This is about the quality of life for the people that come to see you. Right. This is not something they just thought today they want to do. This is something they've thought about and looked at for a very long time, and they're coming to see you to look at the different options that they have. How can they increase their quality of life? What can you do for them in those kinds of situations? And I think there are so many options, like you said, that you can help them with. And then the layers of their health insurance, and then the layers of, what are the counseling issues that go along with it, that your office can help with.
Right. Yeah, so we've been working with different mental health therapists in the area. And that's become particularly important now with this COVID crisis that we're in, because I had a lot of patients scheduled, and then because of canceling elective surgeries and things like this, I ran into problems. However, I don't consider these elective surgeries. They're medically indicated procedures. It's to treat gender dysphoria, and so that's how I've been able to sort of argue with the hospital that, hey, these aren't elective procedures and it needs to get done. And so I know the patients were on board with this. And so we spoke to the patient, the mental health therapist, and we've been able to continue our gender affirmation procedures through the COVID crisis, because these aren't elective procedures. They're really treating a medical diagnosis.
What do you think are some of the biggest hurdles that people are when they come to see you? What are some of the biggest hurdles that they are going to have to overcome when they come to see you if they decide to move forward with the process?
Well, one is paying for the procedure. And so I think that's one of the biggest hurdles. Everything else is the hormonal therapy is not as expensive. So a lot of patients end up getting them through the black market even today. And then a lot of them there's a lot of sources for the mental health aspects, like SunServe and Fort Lauderdale is huge. There's a lot of avenues for them. And now, as far as the procedures go, we work closely. We take Medicaid insurance, we take Medicare. I really want to be there for this population, and so unfortunately, we can't do out-of-state Medicaid. So I have to only do that in Florida. Now, what we have, our office manager will talk to them and say, look, these are the insurance plans. Even though you have an insurance plan that may not cover the procedure, then there's options for them where they will cover them. They might have to pay a little bit higher premium, but there's certainly options for them to cover the procedure. So I think that's one of the challenges is insurance coverage for the procedure. But a lot of them are very savvy. A lot of patients are very savvy, and they'll find out exactly how to get these procedures covered. And thankfully, insurance companies have been pretty good about covering them.
We've turned to a lot of corners, I think, in our country for covering these. I know we're, as you said, behind a lot of other nations that have covered this for insurance, realize it's necessary. But I think we're catching up a little bit more so than the other countries that have done a better job at covering this for insurance.
Yeah, I definitely agree with that, especially I've seen the evolution in the last 10 years, and it's, thankfully, despite the current political climate, we've still been managed to be able to, get insurance coverage. And I know I've also worked with the Transgender Legal Defense Education Fund, or the Defense Fund, and so.
Okay.
And they, they've been very savvy with helping with insurance and companies' coverage of these procedures as well.
Mm. We were a media sponsor for Southern Comfort, if you're familiar with them. That was the transgender conference that was here in typically until this year, obviously because of COVID. Was here as a really phenomenal conference for the trans community, and I loved going and hearing their stories, and it was just. They're just really amazing people to get to know, and everyone's at a different place in the process. And I loved going to that conference. I look forward to it coming back. And that interconnectivity that they have was really phenomenal. I was fascinated to hear them and see them come together at that particular conference. So are there any other ways that you would suggest people could connect with each other in the trans community?
So yeah, I agree with you with that conference in particular. I've presented at that conference in the past. It's really an amazing conference. The other one is, there's the WPATH, the World Professional Association for Transgender Health. They have a conference every other year. I'm not sure what's going to happen now with conferences, but
sure.
And then there's also now a U.S. PATH. It's a United States PATH, Professional Association for Transgender Health that's been pretty famous with, it's sort of where you have actually not only physician scientists, but also patients that actually attend the conference. That's what's been unique about the Southern Comfort, is that patients and physicians go to the conference, so they're able to sort of mingle and ask more intimate questions, if you will, if needed to.
I would imagine that when patients come to see you, there's a blend of fear and excitement. Because there's a lot of unknowns, but an excitement of a future that they've looked forward to. How do you work with both of those to create a treatment plan for your patients that have both of those elements?
So the fear part, I maybe end up instilling even more fear. What happens with my patients when they come in, I really want them to know what they're getting themselves into, because they're invasive procedures, and so. I have a video that I showed anybody who's a transgender man, and for transgender women, a different video. And it goes over all the procedures that we offer. And it actually shows a lot of in surgery, procedures, which is it can be a little bit gory. I certainly warn them, hey, it's going to be a little bit gory. But once they see that, I think then they realize no one's ever run out of the office. And then, frankly, a lot of patients have seen so many YouTube videos. Some of them come in saying, this is exactly what I want. And then the fear part, I really tell my patients that I don't do procedures and then discharge them the next day. Like most of my patients, that a lot of them, 90%, live outside the state of Florida. And when they come in for an operation, both Palmetto General Hospital and Coral Gables Hospital have been very good with our patients. They treat them like VIP patients. Grab a person that's a patient advocate just for the transgender line. And for my transgender patients. And so I tell them that, I'm going to be committed to them, and that if we're going to entertain an operation and take on an operation, I'm going to be with them from beginning to end. I'm not just going to operate on them and put them in a hotel with a nurse for the night or the next couple of nights. So they stay in the hospital with us, and we treat them really like family. And the other thing we do, Dr. Steve, is everyone's working on a different budget. And so some of them will actually just fly in from the airport to the hospital, pack their bags, and then they go from the hospital back on the plane, after they've recovered. So I never send anyone home, sort of. And then the other thing I do is I find follow-up for them in that city that they're in. So if it's a urologic procedure, like it's either a transman operation, the phalloplasty, for example, then I get follow-up with a urologist in that city that they're in, or an OBGYN if it's a trans woman for bottom surgery. And so they feel pretty comfortable knowing that they're going to be able to have that follow-up in the city that they're living in after they leave Miami.
Okay. And tell me again, what percentage of your patients are not in Florida or South Florida, did you say?
It's been about maybe 85%.
Okay.
85, 90%.
So they come here to see, so they see their practitioner there. There's specialists there. They come here for the surgery with you.
Correct.
And then they go back home for their follow-up visits with their OBGYN or their specialist.
That is correct. Yeah, and they maintain contact with me. I'll do a Zoom with them, conference, or emails, and they send me photos. So you know, and then every 6 months we call them to check on how they're doing. But that's how we've been managing it.
Okay. That's fascinating. That, I mean, it takes that basically supply chain of everyone, you know, in contact with the patient, but coming here for that. This is fascinating. What other words of encouragement, or what other words would you give people that are considering this? Because I know we have a lot of readers, a lot of viewers who have been thinking about this for a while. What kinds of things would you like to tell them as they're thinking about this process?
I think, you know, I think now, as opposed to 10 years ago, there's more surgeons that are becoming adept at the procedures. I think in plastic surgery in general, there's been a big rise in the education of surgeons to perform transgender surgery. There's still, for facial feminization, I think it's not as difficult for patients to find surgeons to perform the facial feminization procedures, and also for top surgery, that's augmentations and mastectomies. I will warn patients that with genital surgery, there still aren't that many surgeons that really know what they're doing with the genital operations. I've been seeing more and more revisions as time has gone on, and I'll ask the patients, you know, who did your operation, and it's still. When it comes to genital surgery, there's still a limited number to do it, and they'll tell me the name, and I've never heard of the person, and they'll tell me, oh, well, they've done 500 cases, and unfortunately, you run into this a lot with plastic surgery. Is you'll see a physician, they'll say, oh, I've done, you know, it's in private practice, they'll say I've done 1,000 of these, and that may not necessarily be true. So when it comes to the genital affirmation procedures, I think you have to really study. And make sure that ask to see photos, post-operative photos, when you do your consultation with your surgeon. You really want to make sure that you're with someone who's got some experience when it comes to the genital operations. I think the top surgery and the facial feminization, it's a little bit easier to find surgeons that know how to do these operations. So that's one thing I sort of warn, because it's unfortunate when I see these sometimes operations. I hate to use the word botched as plastic surgery, but sometimes I see operations that have not been performed well to a high, you know, and so that's the only reason I would sort of warn patients. The other thing is you want to make sure your surgeon is getting, for top surgery, you need one letter from your mental health therapist recommending the patient for surgery. And a lot of insurance require that. They won't let you take a patient through the operating room without that one letter recommending the patient for top surgery, and then 2 letters for bottom surgery. And I think that's important, Dr. Steve, because right now the regret is still low. I mean, a lot of the quoted literature says less than 1%. And so the last thing we want is for patients to start regretting this, and then this gets out in the media, this gets out in papers, and then for those sort of right-wing conservatives that don't support these operations, this is ammunition for them to say, hey, we're not covering these procedures anymore. These individuals don't know what they want, and this type of thing. So that's why it is important to have your mental health therapist involved with the surgeon, with the patient. It's really a 3-way decision. Most of surgery is 2 ways: the patient and the surgeon. But in these operations, it's a 3-way decision, and that's fortunately why regret is so low. 1% maybe.
And that's a good point to make. This is because this is so different than knee replacement or typical surgery. This involves multiple layers, and so having all of that paperwork, having all of those other people in conjunction to make sure this is what the person really wants, because then when you go in, it's what they want and they're happy with it. And it goes back to the quality of life. We want the people to have an increased quality of life. This is something they've thought about. This is something they've thought through. They've thought through with the appropriate mental health people, and they've thought through with you. And I think a question for me is, you when you get to the point, you've step through with people at multiple layers. When you go into the OR and come out, what's it like to feel like you've gotten to do this for someone, this is the right thing? That must be an amazing feeling I remember what it was like seeing the medical students get their diplomas.
Right.
What must the feeling be like to think I've been through this process? Because you probably have a little more of emotional connection maybe with some patients because of all of these layers. Is there an emotion at the end of the when you come out of the OR and think this is what we worked so hard for?
Yeah, Steve, so while the patient's still asleep in the OR, it's very satisfying as a surgeon trying to get the best functional and the function you won't know until the patient's already awake and already using that, if it comes to genital surgery. But aesthetically, while you're in the OR, knowing that you've been able to complete an operation. And I will tell you that some of these operations are, when it comes to the intricacies involved, for example, in a phalloplasty, there's some of the hardest operations you have in plastic surgery, because not only are you dealing with microvascular, so you're sewing up arteries and veins with sutures that's thinner than your hair in a microscope. There's also the urologic component, so you're connecting like the urethra, and then there's also just the nerve component where you're connecting nerves. So you don't get that in a lot of plastic surgery procedures. So that's the fulfilling aspect for me, is just doing such a complex operation, such a high level operation. And then when the patient's awake and they see that they no longer have a phallus or no longer have, the female counterpart, and they're just ecstatic. And so again, like I brought up the analogy to treating a cancer patient, and because they're just like, they're almost even more relieved and so much more happier. I mean, it's and that's probably what really continues me to draw me to the field, is that aspect of it as well, because they're so excited and so thankful that you've been able to accomplish this for them. The other thing is, I've even had patients, because I've had a patient who was 80 years old who was undergoing the operation, and that's another thing that sometimes people don't understand. They say, oh, why did this person wait so late? And anybody that's transgender knows this, that, there's no perfect time. The perfect time could be, let's say, if their parents passed or their kids moved out or they finally finished working. Everybody's timeline of transitioning is completely different. And so I'll have patients that might be like 80 years old that will want to undergo the operation. If they're medically cleared, I'm going to do the operation. And they've even told me, listen, if I don't make it through this operation, I want you to finish the operation. If I don't make it from a cardiopulmonary standpoint, I want you to finish the change, the gender affirmation change, while I'm there on the operating room table, because I don't want to go to my grave with the wrong parts. I mean, that's
wow. It's it's having sat at the table with surgeons and developed the curriculum and looked at their clerkships and to sit and talk with them and think that they have a person's heart in their hand, or what they do. I can't imagine that level of responsibility, but I love talking with the physicians and the surgeons and what they do, and how it branches out. But obviously you take a lot of pride in the people that you work with, and the stories that they have. And I know I've had a couple of minor things myself, but that invested interest in the people, in knowing that you're not just going from one point to another, but the total change that they have been looking for, the total change that they have been, like you said, thinking about since maybe they were 5 or 13 or 50 or whatever it is, and that quality of life that you are able to provide them. And it is so different that I think that almost any kind of procedure that we could do for people. So I'm sure you have a million stories that you could tell of what you've talked to people.
Yeah, it's great, and it's certainly my favorite operations, my favorite type of person to be involved with in their care, and it's flattering that they allow me to be a part of it.
I learned that the patient-centered medicine, if those are watching that don't know what that is, Google it and look it up. It is the way of practicing medicine in which the physician takes the care and interest of the person and relates that to their their treatment plans. And that's what we're talking about today, is how your quality of life is changed as a result of what you see in your physician and how your physician works with you. I think you do an amazing job of that, obviously, in the way that you care for people, not just in the procedures, not just in the quality of work, but how you work with your individual patients on an individual basis and take that care. So I really appreciate that.
Thanks, Dr. Steve.
Thank you. Is there anything else you'd like to share? We've been talking for a half hour. Is there anything else you'd like to share? Or we could probably talk for another 4 hours. I do want to mention one of your books. Arthur's going to pull that up. Gender Affirmation, Medical and Surgical Perspectives for Clinicians and Surgery Residents. That's a mouthful. Obviously, that's an amazing textbook for medical students and those in residency. There's not a lot. I worked in medical education. There's not a lot of curriculum, either for UGME or GME in reconstructive surgery. So I think this is amazing that this is out there for people.
Thanks, Dr. Steve. And it's really I feel like a bridge between the U.S. and Europe and Eastern Europe. The other author is Dr. Stan Monstres in Ghent, Belgium, and Miroslav Djordjevic is in Serbia. And so those were two authors that, initially, as I said before, that they were doing really, everyone from the U.S. was flying to get these procedures done in Europe and Eastern Europe. And so I was able to collaborate with them, and that's how the book became so popular. It was actually the #1 selling book in plastic surgery in 2018. And so I felt like it was a sort of the bridge and to bring these procedures to the U.S. And now, we get patients flying from Europe and Eastern Europe for these procedures. So I was pretty happy that the U.S. now is actually propelling forward in this field.
I helped start the College of Medicine at Florida International University and was the director of clinical education. And surgery was one of the clerkships I worked with. And I worked with the surgery clerkship at the University of Kentucky. And one of the things about medical education is that every minute from the day a medical student starts till they end, every minute is booked with something for them to do. But this really needs to be added even more into the undergraduate medical curriculum. Even though it is full, we need to work this into the curriculum so students are more aware of this for those who may be going into surgery, and then how this impacts GME, or graduate medical education programs, whether it's DO or MD, whether they're allopathic or osteopathic medicine, more options and training for this.
Can't agree with you more. And now there's more universities that are doing these procedures. I think before the insurance coverage, it was a lot of private practice physicians that were doing it, and they did a great job. Marcy Bowers obviously is one, and but now, more and more universities are taking these procedures on, and so that's why I think now the exposure to the medical school education can be enhanced because of that.
They need, if we can get it started in the beginning, maybe even introduce it into the gross anatomy classes in the first year, and get the discussion started in first year in gross anatomy and some of the other courses. And then the courses that need to then relay into the patient-centered medicine courses and into the patient skill settings, because they're going to have patients come to them and talk to them. And how are they going to be able to deal with that from a counseling position right at the very start when patients come and talk to them? It's not, I haven't seen it a lot in the curriculum in UGME, but it's something that we need to be having that discussion for. So very good, very interesting talking to you. We're going to put up your website so people can find you. And Arthur's going to put that up for us. Your Constructive Surgery Associates. There in Miami, Florida. We have your office number and your Instagram and all of your information.
Okay, thanks. And the website is constructivesurgery.org. Thank you so much, Dr. Stephen.
We've got it. Thank you for talking to me. This is fascinating. I feel like we could talk all day and go down multiple avenues. So if there's anything I didn't ask you'd like to share, this is the time.
I think it was very comprehensive and you covered quite a bit. So I'm good. Thanks.
Thank you. The last question I always ask everyone during this session is, because this is a difficult time for everyone, what words of encouragement can you give people during this difficult time? I'm going to put you on the spot. I didn't give you this ahead of time.
That's okay. Well, I think specifically for the patient population we're speaking about, don't feel alone. Know that, now thankfully physicians are offering telemedicine consults that can be performed. And this is something that I certainly never had done telemedicine consults until this crisis started. Do wear your mask. And I think that's the most important aspect of the whole crisis is, in addition to the social distancing, but wear your mask and seek out, there's a lot of outlets out there to find out a good mental health therapist or endocrinologist and surgeon. We are doing these surgeries during the crisis. And again, telemedicine visits are available by most physicians. So don't feel that, everything's on hold now because of this.
Very good. Let me get myself back in there, Arthur. There we go. Yes, there are lots of telemedicine, whether it's phone, video, or other options. There are a lot of healthcare alternatives out there for people. So I used one the other day. Actually, it worked very, very well. So I highly suggest that. Well, thank you very much for talking to us. Again, we are OutClick, OUTCLIQUE.com, or you can text OCQ to 22828 for more information on us. Thank you, everyone, and stay safe.
Thank you, Steve.
Thank you.
Bye-bye.